Hi everyone. I'm so sorry I can't be there with you for this lecture. However, I hope that this video recording will do justice and will help this poor grumpy cat, as well as you guys, to feel happier by the end of the lecture. So let's start. What we're going to do in this lecture is firstly, to give you an explanation for the basis for the use of the various types of antidepressants. And of course, because this is pharmacology, we also have to delve into the mechanisms of actions and also adverse effects. And of course, relate relevant pharmacokinetic aspects to the therapeutic uses of these drugs. So understanding the rationale or the basis for the use of antidepressant drugs in depression is really understanding the biogenic amine or monoamine hypothesis of depression. So what this hypothesis says is that depression is due to deficiency of monoamines at certain sites of the brain. So what are monoamines? They are your noradrenaline, serotonin, and dopamine, right? So the deficiencies of these three main monoamines are the reason why you get depression. So that's what it says. And how people came up with this hypothesis was really based on the observation that when certain drugs that facilitate monoamine transmissions are given to patients with depression, they seem to alleviate depressive symptoms. So they said, okay, so if we give something that can enhance monoamine transmission, so perhaps it really means that people who are depressed do not have enough of this neurotransmitter. So that's how it came about. But the problem is, this is way too simplistic, and there are many shortcomings to this hypothesis, which we will examine in a short while. Right. So the first problem with this hypothesis is that there's no real evidence for levels of monoamines, right? So if you say that it is because of a deficiency in the levels of the monoamines, where is the proof, right? So you should be able to take a blood sample or a lumbar puncture sample to actually prove that the levels are actually low. But no, there is no real proof. And secondly, some clinically effective antidepressants actually lack actions that enhance monoamine transmission, like benzodiazepines. It has nothing to do with monoamine transmission, and yet it works. And some of the newer antidepressant drugs that are still in clinical trials and development are things like glutamate antagonists, melatonin agonists, glucocorticoid-specific agents that has got nothing to do with the monoamine system, right? So that's the other problem. And the next shortcoming is really when people have looked at studies looking at imaging of the brain and whatnot, some of the biochemical changes associated with depression are really identical to patients with mania, which, to explain this, mania is actually at the other spectrum of the disease. So if depression is something to do with low levels of monoamines, mania is like a lot of monoamines, like dopamine and so on. And the other thing is that antidepressants have delayed therapeutic effect. So if we say that depression is a simple case of low levels of monoamines, when we give the drugs, the effect that you see to increase the neurotransmitter level actually happens almost immediately. However, the clinical effect of antidepressant is not seen until weeks later, right? So why do this happen? So people have hypothesized certain things in relation to the delayed effect of antidepressant drugs. So the first hypothesis in the hypothesis is that neuronal loss in hippocampus in prefrontal cortex in depression is alleviated by regeneration of these neurons in these areas, right? So if you give antidepressants, somehow you tend to trigger neurogenesis in these regions, which is really something quite recent, right? This idea, because I remember when I was in medical school, we always say that neuronal cells cannot regenerate, right? But more and more evidence are accumulating to say that this is actually not true. If you see in cases of extreme stress and pain, brain-derived neurotropic factor, or BDNF, is reduced, right? And with reduction of this BDNF, you get atropic hippocampus, prefrontal cortex, and also the anterior cingulate gyrus, which are actually seen in people with depression. So when patients are given antidepressant drugs, it triggers a cascade of events to produce neurogenesis in these areas, and they inhibit apoptosis at this area. So if you look at this diagram here, so stress stimulates the release of glutamate, which then acts on the NMDA receptors to directly trigger neural apoptosis. On top of that, stress also causes release of cortisol, release of cortisol from the adrenal cortex, which then stimulates detrimental gene transcription response to stimulate neural apoptosis again. So you get death of neurons. On the other hand, if you have something that stimulates the release of noradrenaline, 5-HT, or BDNF, you actually stimulate the opposite side, right? So the genes that are supposedly beneficial for neurogenesis and inhibiting the genes that are supposed to cause neural apoptosis. So at the end of it, you get alleviation of depressive symptoms by these drugs. So another hypothesis that people have actually put forth for the reason why there is delayed effect with antidepressants is that, right, so if you imagine the cell membranes of your neurons in the brain, right, so they're not actually a smooth surface, so it's a little bit bumpy, right? It's not quite like this, it's a little bit bumpy. So GPCR is the receptor for your monoamines, right? And upon activation of the GPCR, upon binding to the ligands, it needs to couple with the G-alpha and the other downstream signaling pathway molecules to actually trigger the cascade. But because the membranes are not smooth and bumpy, so the GPCR and the G-alpha portions are at different regions, right? So the GPCR is on the bumpy side and the G-alpha is on the smooth side, so there is a disconnect. So what happens is that when you treat the patient with antidepressant drugs, so these drugs get deposited on the membranes and they sort of displace the GPCRs back to the same plane where the G-alpha molecules are, right? So then it sort of like connects them again, and upon binding with the ligand of the GPCR, so the downstream signaling pathways are able to follow. Right, so enough with the hypothesis. We go on to the antidepressant drugs proper. So now I have actually divided the drugs into first generation and second generation. And some people just classify the drugs based on these various classifications, right? There are many ways to classify it, but I've decided to show you the first generation and second generation. So the first generation of antidepressant drugs like the tricyclics and also the MAOIs, MAOIs, are very rarely used these days because of how much more effective and safe the second generation antidepressant drugs are. And when we talk about second generation antidepressant drugs, the first on the list would be the SSRIs, and then the SNRIs, NDRIs, and even these supposedly low on the list is actually gaining more and more acceptance by physicians and patients alike because of how well they work. So now, let's take a look first at the SSRIs. So SSRI stand for Selective Serotonin Reuptake Inhibitor. And the good news is this is exactly how they work, by selectively blocking the reuptake of serotonin. So easy, right? So the name indicates how it works. So that's one job done for you. So SSRIs are really used as first-line treatments for depression and anxiety, mainly for the safety in overdose, right? And even though people say that tolerability should be better with SSRIs because it should have better side effect profiles compared to older drugs or the first generation drugs like tricyclics and MAOIs, clinical data have actually indicated that patients actually tolerate both groups of both first generation and SSRIs pretty similarly, right? So in theory, it should be better tolerated, but in actual fact, it's about comparable. But the main thing that sets apart SSRIs and the tricyclics and MAOIs is really the safety and in overdose, particularly with tricyclics. All SSRIs have similar mechanisms of actions in that they block the reuptake of serotonin. Right. So how it does this is that when serotonin is released into the synaptic cleft, they are reuptake by the 5-HT reuptake transporter so that it can be recycled by the presynaptic neurons. So when you block the reuptake transporter, you're essentially increasing the concentrations of serotonin in the synaptic cleft so that you have more serotonin to bind to the 5-HT receptors on the postsynaptic membrane, right? And as I've said earlier on, antidepressant drugs actually take several weeks to show efficacy, and the reason has been explained to you in the first part of the lecture just now. So some examples of SSRIs include fluoxetine, fluvoxamine, citrulline, paroxetine, citalopram, and escitalopram, just to give you some few examples. At the moment, actually, escitalopram and citrulline is used a lot, particularly in our setting. But fluoxetine was really the prototype of the SSRIs. And what studies have shown is that escitalopram apparently works better than citalopram. Citrulline works better than fluoxetine. And fluoxetine and paroxetine is about equally effective. But citrulline has more adverse effects compared to escitalopram, right? So there are some plus and minuses for each of the drugs. So apart from being used in depression, there are other conditions where SSRIs can also be used. And these include things like anxiety, obsessive compulsive disorders, post-traumatic stress disorders like PTSD, panic disorders, eating disorders, and the adverse effect profile is more or less the same too. Okay, and it is funny that even though one of the indications are actually anxiety, but the drug may also cause anxiety or akathisia. Akathisia is a feeling of being very restless, so it may cause this. And they say that one of the reasons why people have associated the use of SSRIs and massive shootings, if you remember, right, the mass shootings in schools, is linked to this feeling of restlessness and being very aggressive. And this can occur very, very suddenly. So for this reason also, the FDA, have issued a black box warning for SSRIs for the use in teens, right? Because it may actually induce this aggression. Apart from that, it can also cause insomnia, although in some cases it may cause sedation. It can cause GI upset, anorexia, sexual dysfunction, discontinuation syndrome, right? So when you want to take patients off SSRIs, it has to be done step by step. And the other important point for you guys is actually serotonin syndrome, which can happen with drug interaction. I'll show you this in a short while. And like I've mentioned just now, the FDA black box warning says that there is an increased risk of suicide in adolescents, suicide and also aggression, right? So kill other people and also kill themselves. Okay, so I'd like to talk more about the serotonin syndrome. Serotonin syndrome is actually quite rare. It's quite a rare adverse effect, but it's important because it's potentially life-threatening. So what happens is that when you have two drugs that enhances serotonergic activities in the central nervous system, then you get too much serotonergic activity, right? So you have two drugs that enhances serotonergic activities, then when there are too much serotonergic activities, then you get serotonin syndrome. And this can happen with a combination of any serotonergic antidepressant. So if you're giving a patient two drugs that are enhancing serotonergic transmission, you can get serotonin syndrome. Or if you're giving a patient SSRI in combination with, for example, opioid analgesics like pethidine, fentanyl, dextromethorphan, or tramadol, you may actually trigger serotonin syndrome. And this is important because these are the sort of drugs that you will be using in your clinic, right? So you have to take note of this. However, this interaction is not seen when given together with morphine, although it's seen with tramadol. So it's not all opioids, but some opioids. On top of this, it can also occur with any serotonergic drugs taken alone, right? But the chances are lower compared to if you give two drugs that are enhancing serotonergic actions. So this cartoon here shows what serotonin syndrome is all about. So it includes mental status changes, autonomic instability, neuromuscular hyperactivity, and these are some of the causes. And serotonin syndrome is actually very similar to neuroleptic malignant syndrome, which we will also see when we do the antipsychotic lecture. But the morbidity and mortality is lower, so that's the good news. Although the onset is more rapid, it occurs more suddenly. Okay, so we look at the prototype of SSRI, fluoxetine. So when fluoxetine first came into the market, right, everyone was, it was a big hoo-ha, right, because it was free of the tricyclic troubling adverse reactions, particularly in relation to arrhythmias. So it was a very safe drug, and soon it became the most widely prescribed antidepressants in the US at one point, although now it's been taken over by newer antidepressant drugs. So this drug was initially derived from the antihistamine drug diphenhydramine. Right, so the drug is usually taken orally, daily, but there are also weekly preparations available. It has a long half-life, and the half-life actually increases after multiple dosing. Now, the important point to remember about the metabolism of this drug is that they are metabolized by the hepatic cytochrome P450 drugs. And for this particular drug, they are metabolized by CYP2D6 into an also active metabolite, norfloxacin, with an even longer T-half compared to the mother drug. So the indications are similar to the other SSRIs, right? It's indicated for people with moderate to severe depression, bulimia, obsessive compulsive disorder, and if you remember the other conditions, including anxiety, OCD, and so on. Adverse effects, again, very similar to the generic SSRIs: anxiety, aggression, insomnia, extreme anger, and hostility. Another important one is that it can also reduce seizure threshold. So people with epilepsy, you have to carefully consider whether or not you want to give this drug. and again, suicidal tendency with SSRIs. Drug interactions, there are many drug interactions because of the fact that they're being metabolized by the cytochrome P450, right? So it can interact with MAOIs, can cause serotonin syndrome. They can interact with lithium, which increases the risk of serotonin syndrome as well, and increased incidence of lithium toxicity, although the combination is quite popular. So you really have to monitor patients who are on this combination drugs. Again, another one, you have to be careful if they're given together with diazepam. Okay, like sometimes some dentists also use diazepam because they can inhibit diazepam metabolism, so they can enhance the actions of diazepam. And also, for patients on warfarin, they may also increase risk of bleeding, again through interactions with the cytochrome P450 enzymes. Right, moving on to the second group of drugs, or the class of drugs, serotonin noradrenaline reuptake inhibitor. So SSRI is selective to serotonin, but SNRI, the reuptake, blocks both serotonin and noradrenaline. Okay, so that's easy. So examples of SNRIs include venlafaxine, desvenlafaxine, and duloxetine. These are some of the commoner drugs used. And now it is actually recognized as one of the first drug choices, along with SSRIs and also the NaSSA class of drug. Some studies have actually suggested that venlafaxine are even more efficacious than SSRI as a class, right? And as mentioned before, they block both the reuptake of serotonin and noradrenaline, and they also work on dopamine at higher doses. So again, they have active metabolites. They're converted to desvenlafaxine, which inhibits noradrenaline reuptake. And the drug has faster onset and better efficacy and tolerability than SSRIs. So they're particularly good for patients who are treatment resistant. Other indications are also quite similar to SSRIs, plus it can also be used in chronic neuropathic pain. And this is because of the actions on noradrenaline. Now, if you look at any antidepressant drugs, which has the effect to increase or enhance noradrenergic transmission in the CNS, usually this also contributes to effective therapy in chronic neuropathic pain because of the noradrenaline actions on the pain pathways, right? You can look that up. Adverse effects include increased blood pressure, and if you discontinue the drug quickly, you can also get discontinuation syndrome, similarly to SSRIs, right? And the good news is that it has fewer anticholinergic adverse effects. The next class of drug is NaSSA, or the noradrenergic and specific serotonergic antidepressants. These are also known as monoamine receptor antagonists. So either one, right? So some people call them as the MRAs, some call them as the NaSSA. So I have put both names here so that if you see this in other materials, so you will know what it is, right? And the prototype drug for it is mirtazapine. So the good thing about mirtazapine is that studies have shown that they have superior efficacy compared to SSRIs or even SNRIs, right? And it has minimal or low potential for drug-drug interaction. And it is also one of the antidepressants that can be used in major depressive disorders with sleep disturbances, right? So for this reason, it has really pushed NaSSAs and MRAs onto one of the first-line antidepressant drugs. So how they work is slightly different in that they block the alpha-2 and hetero receptors. I will show you what alpha-2 and hetero receptors are. So what they do is that they increase the noradrenaline and serotonin release, right? And then on top of that, they also block the 5-HT2C and 5-HT3 receptors. And the blockade actually causes more enhanced 5-HT1 mediated transmission, which is what you want, right? It's not the 5-HT2C or 5-HT3, but you want increase in 5-HT1. So there are so many subtypes to serotonin, and it is the 5-HT1 which has been linked to depression. So the net effect of these two is really an enhanced noradrenaline and serotonin release from the neurons. So if you look here in this diagram, so this diagram here shows a noradrenaline neuron and also a serotonergic neuron. So this is an example of an alpha-2 autoreceptor, and this is an example of an alpha-2 heteroreceptor, right? Although actually technically both receptors can exist on the same neurons, right? But I have put them separately here in this diagram just to highlight to you how they are different, right? But basically, alpha-2 receptors are involved in negative feedback for neurotransmission. So what happens is, let's say when noradrenaline releases noradrenaline into the synaptic cleft, some of these neurotransmitters will bind to the alpha-2 autoreceptors on the presynaptic neurons to signal to the nerves to stop releasing more noradrenaline. So they're negative feedback, right? And this is called an autoreceptor. So now this receptor is called a heteroreceptor because on top of the fact that it can regulate negative feedback for serotonin release, remember this is serotonergic neuron, it can also regulate, it can also be regulated by the noradrenaline release from the noradrenergic neuron here. So the neurotransmitters released here can also bind to this alpha-2 heteroreceptor to reduce the release of serotonergic neurotransmitters into the synaptic cleft, right? So the difference between autoreceptor and heteroreceptor is that heteroreceptors are only regulated by neurotransmitters released by its own neuron, while a heteroreceptor can be regulated by the neurotransmitters released from its neuron as well as a neighboring neuron that releases another type of monoamine transmitter like noradrenaline, right? So I hope that's clear. So the adverse effect for this drug is dry mouth, weight gain, and sedation, which is really due to the histamine effect. And for this reason, it should be administered at night. And if you remember, patients with depression, with sleep problems, it is recommended that they take this drug because of this sedation effect. Right. Moving on to the next class of drug, the noradrenaline-selective reuptake inhibitors, the NRIs. So some of the drugs in this class is Atomoxetine and Amedalin, which are pure NRIs. And there's also another drug which is not really pure NRIs, and this is bupropion. So bupropion, they inhibit the reuptake of noradrenaline and also weak dopamine reuptake inhibitor, right? So they're supposed to be noradrenaline selective. They have put bupropion into this class of drug, but it also has a weak dopamine reuptake inhibitor, right? So slightly more. These drugs are metabolized in the liver by the CYP2D6 to active metabolites such as Venlafaxine. Indications for this drug include depression with anxiety and slow-release formulations to treat nicotine dependence. And this is particularly for bupropion and not these other drugs. Contraindications for this drug include epilepsy. It is contraindicated to be used with other MAOIs, and also in patients with active liver damage because they're metabolized by the liver. And adverse effects include seizures, tremors, sweating, dizziness, anxiety, and aggression. And again, drug interactions are important because they inhibit CYP2D6. So the fact drugs that are metabolized by this enzyme, for example, antipsychotics, beta blockers, clofeniramine, metoclopramide, and also SSRIs. Right. So I'm going to go briefly over this other class of drugs. So this one is called the melatonergic agonist and serotonergic antagonist. So agomelatine is an example. So what agomelatine does is that it works as an agonist at the melatonin 1 and melatonin 2, short form as an MT1 or MT2 agonist. And they're also antagonists at 5-HT2C. So the thing about this drug is that more and more evidence is coming up to show that they're really as effective as other antidepressant drugs while having less adverse effects. But it's a slightly newer drug, so we need more and more data. And also, because it is newer, usually that also means that it's more expensive, right? And generally, antidepressant drugs are considered expensive. And although they may cause a slight increase in liver enzymes, but usually liver injury is quite rare. The next class of drug is a multimodal serotonin modulator. An example of this drug is vortioxetine, which acts by inhibiting the reuptake, selective serotonin reuptake, and it also works as an agonist at the 5-HT1A receptor, and also partial agonist at the 5-HT1B receptor, which are autoreceptors, with also multiple effects on other 5-HT receptors, but these are less well understood. Right? And what is interesting is that they seem to improve cognitive and functional domains of the brain, but it is less effective than SNRIs, but with less adverse effects than SNRIs. So for any reason, if the patient cannot tolerate any of these other drugs, then perhaps this can be an option for these patients. Some of the adverse effects include nausea, vomiting, and also hyperhidrosis. Okay, so I want to walk you a bit through some of the first generation antidepressant drugs because sometimes they're still used and sometimes for other indications, right? So let's go through tricyclic antidepressants. So they were marketed like way back to the 1950s and in fact perhaps even before then. And some examples include imipramine, amitriptyline, nortriptyline, desipramine. And how the name came about was because of the fact that it has these 3 cyclical rings. So they're called the tricyclics. However, nowadays they're no longer the first line because it has many adverse effects. And particularly, it has a very poor safety profile. Right? So the main reason they're not first line is really to do with the safety profile. Pharmacokinetic aspect, they are rapidly absorbed after being given orally, but they undergo significant first-pass metabolism. They are highly protein-bound with high lipid solubility and large volume of distribution. And they are metabolized extensively by demethylation, aromatic hydroxylation, and glucuronidation in the liver. So you can imagine how much drug interactions this drug is going to have. So how this drug works is that it blocks the reuptake of noradrenaline and serotonin into presynaptic neurons. So again, blocking the reuptake will increase the amount of neurotransmitters available in the synaptic cleft so that it can bind to the serotonergic receptors and also the noradrenergic receptors. But apart from binding to the reuptake transporters, they also block all these other receptors, right? And this gives rise to adverse effects. So for the other mechanism of action of this drug is that it also blocks the alpha-2 autoreceptors, therefore inhibiting the inhibitory feedback mechanism, and again enhancing the neurotransmissions by these two neurotransmitters. So some of the therapeutic uses of this drug includes major depression, panic attacks, ADHD, and remember, because of noradrenaline, it also can be used in chronic pain. So apart from that, the other interesting therapeutic use for this drug is in nocturnal enuresis. So now, do any of you have any idea what might be the mechanism by which this drug works to be used in nocturnal enuresis? Do you know what nocturnal enuresis is? So please find that out. And some of the adverse effects are really because of the non-specific effects, like I mentioned, on the adrenergic, histamine, and also muscarinic acetylcholine receptors. Right? So action on H1 histamine receptor causes sedation. Alpha-1 adrenergic receptor blockade causes postural hypotension. And muscarinic receptor blockade causes dry mouth, blurred vision, constipation, and this would be important to you, right? And if you consider this, right, muscarinic receptor blockade is seen in almost every single antidepressant drugs, and for this reason, many of them also tend to have oral problems due to dry mouth, right? So I think in this way, it becomes important to you. So patients who are on antidepressant drugs probably need more regular follow-ups for dental care, right? So this is important for you as dentists. And another important point for tricyclic antidepressant adverse effects is that it can block sodium channel and it can potentially cause arrhythmias. So the important thing to remember about tricyclic antidepressant is that it is a drug with very low therapeutic index. Low therapeutic index means that if the dose goes up just a little bit, then it goes into toxicity range, right? Because of that, there is also a risk of suicide, because when you give these drugs to patients already depressed, right? So patients who are depressed have tendencies for suicide anyway. So they can actually use these drugs for this purpose, right? And that is why also these newer drugs like SSRIs, SNRIs, NaSSA, and so on were preferred over this drug. But having said that, the newer tricyclics have been proven to be safer in overdose, like nortriptyline and desipramine. But because people are already so wary of these drugs because of this narrow therapeutic index, so they are really staying away from this drug altogether, which is quite a pity because tricyclics work very, very well, right? But because it is not safe, other drugs are being preferred. Okay, because the first principle is do no harm. On top of that, it might also cause confusion, mania, and also sudden cardiac death. And this is probably also related to the blockade of sodium channels. So drug interactions, because it is strongly plasma protein bound, so any drugs that compete with this drug can enhance the effect of antidepressant drugs like aspirin, phenylbutazone, and any drugs that are metabolized by hepatic microsomal enzymes can potentially have an effect on the metabolism of this drug, right? For example, antipsychotics, some steroids. And on top of that, it may also potentiate alcohol effect. So all patients on tricyclics will be advised to stay away from alcohol, right? Because if you remember, alcohol in high doses can cause severe respiratory depression and death. Okay, so this slide here summarizes the actions of tricyclic antidepressant drugs. Okay, just to go through briefly the monoamine oxidase inhibitors, or the MAOIs. And this drug is not used much these days due to many adverse interactions, right? So tricyclic mainly because of the safety profile, and this one because of the adverse interactions. So some of the examples of this drug include phenelzine, trinylcypromine, iproniazide, and isocarboxazide, and also selegiline. So what this drug does is that it non-selectively and irreversibly blocks monoamine oxidase. And monoamine oxidase, or the MAOs, are the enzymes responsible for the breakdown of the bioamines, the monoamines, right? The serotonin, noradrenaline, dopamine. Okay, this is Americanized. Sorry, it should be noradrenaline. And also other monoamines in the terminal. So there are two main subtypes, okay, MAO A and MAO B. And MAO A breaks down the monoamines, right? The noradrenaline, 5-HT, and also dopamine. And MAO B affects dopamine and also phenylethylamine. Now, interestingly, in the gut, inactivation of endogenous and ingested amines are also mediated by the MAO enzymes. So this becomes important in a short while, right? I'll explain to you. And some of these examples of the ingested amines are tyramine. Okay, so MAOIs prevent inactivation of monoamines within the neurons, and excess neurotransmitters will actually diffuse into the synaptic space. So it doesn't really increase the storage of noradrenaline and 5-HT, but it sort of like leaks out slowly, right, into the synaptic cleft. Some of the adverse effects seen are orthostatic hypotension, although the mechanism is not well understood, excessive central stimulation causing tremors, excitement, and insomnia, and sometimes convulsions and overdose. It may also cause increase in appetite, atropine-like side effects like dry mouth, blurred vision, and urinary retention. And sometimes, in rare circumstances, it can also cause hepatotoxicity. Right, now comes the interesting part, the adverse interactions. Now, the reason why this drug is so difficult to use is because it has interaction with food, right? Interaction with other drugs are bad enough, but this drug has interactions with food. And if you're not taking the right food, or if you're taking food in high tyramine content, it can cause hypertensive crisis. Now, usually tyramine is metabolized by MAO in the gut wall, and very little actually reaches the systemic circulation. So if you block the MAO, the tyramine now reaches systemic circulation, and it causes an increased release of monoamines. So they sort of like bumps out the monoamines from the presynaptic neurons into the synaptic cleft. And for this reason, you can see rise in blood pressure, giving rise to symptoms like headache, causing intracranial hemorrhage in severe cases. And on top of that, again, any drug that can enhance monoamine transmission can cause serotonin syndrome. And this happens when you use with other serotonergic drugs like tricyclics, SSRIs, or opioids. Remember what are the opioids that can cause serotonin syndrome? Right, but the good news is there are actually a different subtype of MAOIs, right? And they are the reversible monoamine oxidase A inhibitor, right? So they're reversible and they're specific. And they act on adrenaline, noradrenaline, serotonin, and dopamine. And the side effects are not like the MAOIs because it acts mainly on MAO A and just a little bit on MAO B, right? It's not sedative. And the good news is no special diet is needed with this drug. An example of this drug would include moclobemide, and effect is seen after about 1 week of therapy. It's given orally, well absorbed. The T-half seems to be 2 to 4 hours, but a single dose action persists for about 16 hours. And again, it's metabolized by the cytochrome P450 enzymes, and both the subtype of the enzymes that are involved in the metabolism of this drug has genetic polymorphisms. So then it becomes harder to determine the actual concentrations of these drugs in the patients because of this variation. So again, a little bit of a problem there. Some of the indications for this drug includes depression, social anxiety disorder, and sometimes it can be used together with cognitive behavioral therapy for certain conditions. And adverse effects include isolated bone marrow suppression, hypersensitivity, psychiatric reactions, and if used with other serotonergic drugs, it can cause, yes, the serotonin syndrome. Very good. So this slide here summarizes the properties of monoamine oxidase inhibitors, which you can go through by yourself. Now, I just want to touch a little bit on natural antidepressant drugs. Well, I shouldn't call it drugs. They're mainly like supplements because it is used a lot by patients, and some of them need to have a little bit more careful consideration. Right, so L-tryptophan is a precursor for serotonin. So usually it's not really problematic, but several outbreaks of fatal eosinophilia myalgia syndrome have been seen because of manufacturing impurity. Okay, so not much problem with this. But St. John's wort, right? So this is used widely for depression. So St. John's wort is a type of a herb with many active substances, which includes hypoflorin. And hypoflorin actually acts by inhibiting monoamine transport, right? So it works very similarly to our antidepressant drugs. And although it has very few side effects, it can have drug interactions with our other antidepressant drugs because of the enhancement in the monoamine transmitters, right? So it can cause serotonin syndrome. So other drugs that can be used in depression or as an adjunct or to augment the effect seen by a drug can include things like anticonvulsants. So patients can be on one antidepressant drug with another anticonvulsant drug to control the depression. So examples of this would include lamotrigine, sodium valproate, carbamazepine, and also benzodiazepines. And also some atypical antipsychotic drugs, risperidone and aripiprazole, and some benzodiazepines. So don't worry too much about these drugs. We will learn about them in the next few lectures. So I've prepared for you some antidepressant Edpuzzle video and quiz. You can look at them in Spectrum, right? So I will give you the links to the quizzes, and I hope that the video and quiz will help you understand the topic better. Okay, thank you. Bye-bye.